Mr. Lane, my name is Nicole Reichert. I'm a CSU and BPA student. I'll be conducting your ENT exam today. Is that okay?
Yes.
Great. I'm going to wash my hands. While washing my hands, I'm observing my patient's general appearance and status and making sure that they are awake, alert, and responsive. They're well developed and well nourished, and they're in no apparent distress. I want to make sure we're going to repeat any vital signs that are abnormal, which we would find on the triage area. I'm going to do a quick mental status exam. I'll make sure my patient is alert and oriented ×4. Would you mind stating your full name, please?
Morgan Lane,
What is your date of birth?
04/22/1981,
What's the day of the week?
Wednesday.
And what are we doing today?
Just getting an exam,
An ENT exam.
ENT exam.
Thank you. So with the ENT exam, we're going to be looking at the head. We're inspecting for size, shape, any evidence or trauma. Looking at the face for asymmetry, involuntary movements, expression, and edema. And we're also looking at the hair distribution. As you see, our patient has a beard. We're making sure all the areas it's going, make sure there's no hair loss, even on the eyebrows as well. Okay. Now, in the previous video, we did a whole eye exam. So please refer to that video. We're going to move on to the ear exam. So we're inspecting the external ear. We're looking for any kind of redness, any deformities. We're looking in the front, and we're also making sure we're looking in the back. We're looking for any kind of redness, lesions, swelling, or any kind of deformities or lesions. I'm going to then palpate the pinna, tragus, and mastoid process for any kind of tenderness. So here is the helix or the pinna. We're palpating the whole thing, and we can actually pull it up to elicit any tenderness. Do you feel any pain when I do that?
Nope.
We're going to press gently on the tragus right in the front, and the mastoid process, which is right behind that ear, that bony prominence right here, and we're going to put a little bit of pressure there as well. And making sure we're doing that bilaterally. So pulling up in the pinna, palpating, pushing gently on the tragus, and then looking behind and palpating where the mastoid is. Any pain when I'm touching it at all?
Nope.
Perfect. Okay. We're next going to be doing the otoscopic exam. So we're going to be using our otoscope. We're going to pick the largest speculum that would fit in the ear canal. Now there are adult sizes and pediatric sizes. And if we focus on, we can actually get a size discrepancy. So adult and pediatric. So we're going to use the adult otoscope, making sure our equipment's working correctly. We're going to be holding it like a pencil. My 2 fingers are free, so I'm going to be supporting this against my patient's head just in case there's any movement. It is protecting our patient and ourselves as well. So while I'm doing this, I'm looking at the canal for patency, redness, swelling, cerumen, which is earwax, discharge of foreign body. So what I'm going to be doing is I'm going to be gently pulling up the pinna to kind of straighten out the ear canal. So I pull it up, I put my 2 fingers on the nape of the neck here, and I'm going to insert my speculum by pushing the tragus forward just a little bit and then inserting it so I can see all the way to the back. So again, looking at the canal, then we're looking at the tympanic membrane. Go on this side. For the TM, I'm looking for any injection, perforation, effusion, or contour. And contour meaning if there is any kind of fluid behind there or pressure differences, then we're going to see some bulging of that TM. So again, on this side, pulling up the pinna, placing my fingers kind of on the cheek here, pushing the tragus forward, and inserting using one eye. I'm looking through, and we're looking at the structures of the TM, looking at the umbo, the pars tensa, the pars flaccidea, looking at the handle of the malleolus. Perfect. Okay. And that cone of light, is just a reflection of the light off of the TM, and you're making sure that that is a nice pearly gray color, and we're getting that reflection back. So acuity, I want to make sure I'm testing his hearing bilaterally, which is the cranial nerve 8. And we're going to be, I want you to close your eyes for me. I'm going to be rubbing my fingers in front of your ear. Let me know when you hear it.
I hear it.
Tell me when it stops.
Stop.
Tell me when you hear it.
I hear it.
And tell me when it stops.
Stops.
Good. So his hearing is fine bilaterally. Now, if there was hearing loss in one side or the other, let's say it was the right side, and when I was stopping, he didn't know. When it was starting, he didn't know. There was some hearing loss. I want to use my 512 Hertz tuning fork, and we're going to be performing a Weber and Rene test. And what this does, it determines, is this conductive hearing loss versus sensorineural hearing loss. So what I'm going to do is gently tap this. I'll be putting this at the top of your head, okay? So hear it. We're going to be placing it in the center. Do you hear it?
Yes.
Which side do you hear it more on, or do you hear it equally?
Left side.
Okay, so he's saying he hears it more on the left side. So if he had loss of hearing from just the basic rubbing of the fingers on the right side, but it's lateralizing to the right side, we have to think about, is this a positive Weber test? So if it's a positive Weber that's lateralizing to the good ear, we have to think it's sensorineural hearing loss versus conductive. If it lateralized to the ear that was affected, we're thinking it's conductive hearing loss. So that's the Weber. We do that first. So right now, because it lateralized to the good ear, we're thinking it's more sensorineural. But let's do the Rene test, which is the second part, and see if it correlates with our Weber exam. Okay? So we're going to gently tap our fork. I'm going to be placing this behind your ear. Tell me if you can hear it.
Yes.
Okay, tell me when it stops.
It stopped.
Okay, can you hear this?
Yes.
Okay, so that is saying air conduction is greater than bone conduction, and you're placing the back of this tuning fork directly on the mastoid process. We're going to do the same thing on this side. Okay. So gently placing it on the mastoid process. Can you hear this? Mr. Lane, can you hear this?
No.
Okay, let's try it again. Can you hear that?
No.
Can you hear this?
No.
Can you hear
Yes.
that? You can hear that? Tell me when it stops.
Stop.
Can you hear this?
Yes.
Okay, so air conduction is greater than bone conduction on both sides. So that does correlate with more of a sensorineural hearing loss. Now, looking up conductive is if there's something blocking the sound through the air, so the actual middle part of the ear or the actual canal, that the sound can't get through. So if there was a foreign body or if there was a cerumen impaction, that's more conductive hearing loss. Sensorineural hearing loss is thinking about in the cochlea with all those hair cells in there. There's damage inside the actual hearing mechanism or structures, then we're thinking more sensorineural. That can happen with age, it can happen with loud noise exposure, and other causes of etiology. So that's how we perform the Weber and Rene test. Okay, next I want to move on to the nose. Now the olfactory nerve is not often tested, but if there's any sort of head trauma or your patient's complaining of the inability to sense smell, we're going to test it bilaterally. We can use peppermint, we can use any sort of, maybe an alcohol swab to determine if there is a loss of smell. But I want to make sure that we want the patency of both sides. So would you mind putting your finger on one side and smelling it, and on the other side? So we're testing patency bilaterally. I'm looking at the external nose for any deformities, foreign body, or asymmetry. I'm also going to use my otoscope to look inside the nose. Now, some of your equipment comes with a nasal speculum, which is a little bit larger than this. And there are other equipment that you can use to actually spread the nair. But this is fine. We're going to use the adult size otoscope tip. Have my patient look up for me. Okay. I'm going to, again, have my fingers to stabilize my equipment. I'm using my finger. I'm gently push up on your nose. I'm going to be inserting the speculum on either side. Okay. So what we're looking for is everyone see there's the turbinates. And we actually push out the nair to look. You don't actually have to look inside the otoscope. This is just an observation on either side. And it's a gross looking. So I'm looking at the turbinates and looking for any swelling, looking for a foreign body, especially in children. Love to put things in their nose. So we're looking at the septum for deviation or perforation, for discharge, polyps, and edema. And again, we know how to, I'm going to put it over here. how to take off the otoscope tip. Again, this is in someone's nose. Just gently twist and it comes out. Okay. All right, then we want to move on to the mouth and throat. If your patient wears dentures, please have them remove it. Do you wear dentures, Mr. Lane?
No.
No, okay. We're going to be using additional lighting, so I can use my pen light, or I can use my otoscope, ophthalmoscope, whatever other light source you'd like to use. I'm looking at his lips and buccal mucosa for any sort of redness, lesions, or decay. I'm going to be using a tongue depressor to get a good look. Would you mind opening real wide? Stick out your tongue. Stick out your tongue for me. Good. Say ah. So looking at that soft and hard palate, elevate appropriately, looking for that uvula for deviation. I'm going to put this on either side, looking at the buccal mucosa. Perfect. We're looking at the teeth and gingiva. You can put on a glove and really get in there, which we're going to do. Making sure both the anterior and posterior surface. Would you mind opening, lifting up your tongue for me? Put your head down. And move your tongue, take to the right, yep, and to the left. And then stick it out. And then move it back and forth. Good. Excellent. So I was looking for any kind of decay, swelling, or missing teeth. There are 32 adult teeth, including your wisdom teeth. So making sure you know how many teeth your patient has. We looked at the underside of the tongue for lesions, nodules, or ulcerations. We assessed cranial nerve 12, assessing for deviation, atrophy, or fasciculations. And we moved it side to side, noting symmetry of movement. We looked at that symmetrical rise in the soft palate and that uvula, making sure it wasn't going to either side of the other for deviation. And the last thing I want to do is look really at the far back of the throat, just to make sure we don't forget it, at the tonsils, the tonsil fossa, and the posterior pharynx. This is where we're looking a lot for anyone that comes in for a sore throat, for redness, swelling, or those white spots or exudates. So one more time, Mr. Lynn, open up real wide, using my pen light, and looking at either side of the throat. So there's tonsils on one side and the other. And everything looks nice and healthy. Nothing's red, there's no exudates, lesions, or swelling. Okay. Now, if my patient complained of pain in his mouth, or there is swelling or hardness or nodules, I'd want to use gloves. Let me grab my mediums here. I'm just going to feel around the base of your mouth. And I'm feeling for any kind of indurations, which is any kind of hardness or nodules, looking for any kind of lesions. Okay, so open your mouth for me. I'm going to be palpating around, especially under the tongue. Lift your tongue up for me. Under the tongue. So think about the risk factors for your patient. Now stick your tongue out for me. You can grab a gauze to get a good kind of grab on it, or making sure we're looking at the sides of the tongue. Perfect. For any kind of patches, white patches, or leukoplakia, or any kind of lesions. Let me wash my hands real quick. And the ENT exam, we're also, because we assess the throat, we want to look at the outside of the throat. So we're going to look at the neck for symmetry, scars, and swelling. I'm then going to perform a cervical lymph node exam. We're going to start up top, preauricular, postauricular, occipital, tonsillar, submandibular, submental. Lift your chin up for me a little bit. Anterior cervical chain, again, gentle circles. Posterior cervical chain, so right behind that sternocleidomastoid. All the way down to the clavicles. The deep cervical chain, I'm going to be pulling just a little bit. Perfect, so we're getting a little deeper here. Proper exposure, supraclavicular, the whole length of the clavicle, and the infraclavicular. And we're feeling for size, tenderness, and looking for any swelling. All right, that concludes the ENT exam. Thank you, Mr. Lane. I appreciate it.